Hello, my name is Anna Nowak-Wegrzyn. I'm a professor of pediatrics at the New York University Grossman School of Medicine in New York, and it's my great pleasure to share my experience with food desensitization in the office with you. My learning objectives are to describe the evidence in support of food immunotherapy and to talk also a little bit about different routes of food immunotherapy, to describe the practical aspects of providing oral immunotherapy in the office, and to describe the risks and benefits of food immunotherapy. So, food immunotherapy has really exploded in the past 20 years, and it could be defined as allergen-specific as well as allergen non-specific immunotherapy. And as you can see from that slide, the vast majority of the studies have been focusing on the allergen-specific immunotherapy via oral, sublingual, and epicutaneous route. The allergen non-specific immunotherapy is much less developed, but there's a lot of activity in that space looking at specific biologics that could be used as a monotherapy or combination therapy with allergen-specific immunotherapy. So just as a reminder that we have a long history as allergists of utilizing allergen-specific approaches, and that the first ever published successful report of an allergen-specific immunotherapy was of oral desensitization to egg in a teenage boy with anaphylactic egg allergy. And then you can see subsequent reports on subcutaneous, epicutaneous, sublingual, intralymphatic immunotherapy, as well as the injectable immunotherapy with modified peanut vaccines. And for the US, in the beginning of 2020, we reached a milestone of FDA approval for the first biologic drug for desensitization to peanuts. So oral immunotherapy sort of follows the same scheme as injectable immunotherapy in that there is a build-up phase as well as a maintenance. But the cardinal difference between the oral immunotherapy, which I'm mostly speaking about right now because it's the one that can be used in the office more readily than other forms of immunotherapy, is that most of the treatment occurs at home. So unlike injectable immunotherapy, the patient comes to the office for build-up visits, but then the patient continues the same dose that has been tolerated in the office at home every day around the same time. And there's this buildup that, depending on the desired maintenance dose, depending on the sensitivity of the patient, may take 6 months or longer. Once the desired maintenance dose has been reached, it is continued on daily basis. And at some point in the future, when the biomarkers such as skin prick test, the specific IgE are favorable, there could be a decision to discontinue, test if the patient can ingest a higher dose, like a full serving of the food, and then to test the persistence of protection through purposeful discontinuation of a daily treatment and repeating the challenge. The lower panel of the slide just shows the trajectory of the changes of the immune markers. And I'll just please want to point out that in the first 12 months of treatment, there actually could be an increase in specific IgE levels, but it's sort of paralleled by the increase in regulatory T cells, as well as decrease in the wheel diameter of the skin prick test. So mentioned before that we have now the Palforzia, which is a drug approved by US FDA for the desensitization to peanut. So this is those are the results from the Palisade study through the intention to treat analysis. In that study, the maintenance dose was 300 milligram peanut protein, which is one peanut kernel, for 12 months. This maintenance dose was, I'll explain how it was selected, but the truth is that there's no universal agreement on the maintenance dose. So some of the studies use very high maintenance doses, like up to 4 or 5 grams of peanut protein, or milk, or egg, and while other studies use much lower doses to improve the safety of oral immunotherapy. But in this study, it was a multi-center international study, placebo randomized, double-blind placebo-controlled, which showed that in the group of 4 to 17 years of age, the treatment was significantly efficacious in terms of desensitization. So 75% of the treated subjects were able to tolerate 300 milligram of peanut um, protein, 65%, 600 milligram of peanut protein, and over 50% tolerated 1,000 milligram of peanut protein. And this was compared to significantly lower percentage of patients in the placebo-treated group. There was no statistical difference in the adult arm of the study, but it should be pointed out that this arm of the study did not enroll necessary number of subjects to reach statistical significance, although you can see that there's some trend. So, so one peanut kernel, 300 milligram of peanut protein, two peanut kernels, 600 milligram of peanut protein, and three peanut kernels equivalent of about 1,000 milligram of peanut protein. So this was defined as a ability to tolerate to ingest that dose of peanut without dose-limiting symptoms. So that study led to the approval of Palforzia for children 4 to 17 years of age at the time of initiation for the mitigation of allergic reactions, including anaphylaxis that may occur with accidental exposure to peanuts. So this is not a cure, this is a desensitization, and the protection is maintained as long as the patient is continuing the treatment. Because of side effects that are associated with oral immunotherapy, specifically anaphylaxis, this product contains a black box warning, and it is required that risk evaluation and mitigation strategies are in place. Both patients and providers must enroll, and during the treatment, the patients continues to strictly avoid peanut, but is prescribed epinephrine autoinjector emergency treatment plan and is provided anaphylaxis education at each visit because of the potential for acute reactions. This is true for any food immunotherapy, whether it's milk or egg or wheat. There is an increased risk for adverse reactions. So food oral immunotherapy is an example of shared decision. So shared decision is a process of decision making where as physicians, we explain treatments and alternatives to patients and help them choose the treatment option that is best aligned with their preferences as well as their unique cultural personal beliefs. So as opposed to telling the patient what to do, we are helping them make a decision. And this is particularly important in case of oral immunotherapy because this is a pretty challenging treatment. And I think it's also important to understand what motivates the patient's caregivers to pursue oral immunotherapy. This is a small survey of patients receiving OIT in private practice and with a median patient age of 10 years. And the vast majority of the caregivers said that they were motivated to pursue OIT because of fear of fatal reaction. And we know that fatal reactions are really, really, really uncommon. So here, it's important to misspell that myth, which is driving the patients to enroll in the treatment. And then less than 10% really wanted to eat the food. This may be different for different foods. So, for instance, I'm sure this is true for peanut, but it may this percentage would be much higher for patients who are allergic to milk or egg or wheat, which are the staples in the daily diet. So the shared decision is important because usually the treatment is driven by parents, the caregiver. So for the older children, adolescent, it's important to really understand, for them to understand the sort of agreement to participate in the treatment. It is important to explain exactly what are the results, what are the expected results. We're talking about desensitization. We're not talking about cure. We're talking about ongoing commitment, 4 to 6 years of daily dosing with peanut powder, which requires lifestyle modifications such as avoidance of exercise following dosing, and is also associated with the risk of anaphylaxis and eosinophilic esophagitis. As a judgment, you as a physician, you have to assess, is the patient family reliable and adherent with having their emergency medications, coming for follow-up, using their asthma medications, and what is the family home situation? Is this a stable household, or is the child care fragmented and shared by different family members? Because this would really increase the risk of mistakes and adverse reactions. Um, the question is, how high should the maintenance dose be? So initially in the studies, we were thinking that the maintenance dose should be high. We know that efficacy of allergen immunotherapy is proportional to the dose that is being provided. It turns out that there is a balance between efficacy and safety. So for the study that led to the registration of the drug, the maintenance dose was 300 milligram, one peanut kernel, but it translates into the risk reduction by 95% from accidental exposures. But still, the patient needs to continue to avoid peanuts strictly. But then over time, with continued immunotherapy, this risk reduction may be even higher. So this is just the model that has been used to estimate this 95% risk reduction, which was based on the ingestion of products such as snack, chips mixes, cookies, donuts, and ice cream. I'm referring back to this product that has been approved in the US, but this is true of whether you do oral immunotherapy desensitization with the product or with the actual food. So there is need for time and space for observation. Usually on day one, there is a longer visit, and subsequent visits are shorter, about 1 to 1.5 hour. And then, you can just appreciate that the whole process of the up dosing lasts about 24 weeks. In case of Blepharosia, this is 11 dose levels. And this is the optimal case scenario. If there are any problems, if there's a need to prolong dosing at an individual dose interval, then this process will take longer. So, if you perform oral food challenges in the office, then you are well equipped to provide the oral immunotherapy. But the patient coming for the initial dose escalation, we obtain vital signs, we calculate the medication, emergency medications, have them immediately available. We review the medications, check peak flow spirometry for patients with asthma, perform physical assessment, and then mix the food with whether it's a prescription food or it's a real food. You mix it with other foods, semi-solid foods such as pudding, yogurt, applesauce. Administer the dose, and then after 20-30 minutes, you assess the patient, proceed with the next dose if this is the sort of initial dose escalation. So for the peanut, the final dose is 6 milligram on day one, and then, as we discussed before, upon discharge, you have to verify if the patient is ready to treat anaphylaxis. So here are the pictures of the drug. For the doses, subsequent doses, again, emergency medications are absolutely, required to be available and easily accessible. And then the patient has to be following the in-office dosing. The patient has to be really educated about home dosing. So the dose should be taken the same time of the day, plus minus 4 hours. The food should be mixed with some other vehicle food, preferable after a meal or large snack. You don't want this dose of OIT taken on an empty stomach. There should be a restriction of physical activity for 1 to 2 hours at minimum. The patient should not be taking hot showers within 1 to 2 hours after dosing. And then the patients have to be educated to stop dosing and notifying the allergist for any febrile illness, vomiting or diarrhea, asthma exacerbation, or any other acute illness. As I mentioned before, oral immunotherapy has side effects. So fortunately, most common are oral allergy symptoms. So itchy mouth, throat. Almost 100% of the patient at some time will have this symptom. So that's why it is important to mix the food, immunotherapy food, with another food, and take it after a meal or snack. Sometimes it's helpful to pre-medicate with cetirizine, for instance, if the patient is uncomfortable. But it's important to explain to the patients that this is expected and it means that the immunotherapy is working. Then less pleasant are gastrointestinal side effects such as nausea, heartburn, abdominal pain, diarrhea, vomiting. They are, even those are not life-threatening, they are a common cause of discontinuation of oral immunotherapy. And there are two types of gastrointestinal symptoms. Around the dose, usually present early during oral immunotherapy, likely due to local histamine release, may respond to pre-medication with cetirizine or famotidine, and usually has a favorable prognosis and subsides with continued dosing. However, if the patient develops delayed symptoms unrelated to the OIT dose, then suggest that there's more chronic gastrointestinal inflammation. At that point, we would try famotidine, probiotics such as Lactobacillus GG. Some patients may progress to the eosinophilic-like phenotype, but this is rare, less than 5% of the patients. So the uncommon severe side effects is anaphylaxis, present in less than 1% of doses, but this may translate to up to 15% of the treated patients. And then eosinophilic esophagitis, as mentioned before, usually under 5%. Fortunately, it does result with discontinuation of oral immunotherapy. However, EOE is a contraindication to starting the immunotherapy to peanut or other foods. So you may be familiar with this safety analysis, PACE meta-analysis of 12 studies with more than 1,000 patients. Pediatric patients are follow-up for 5 to 8 years, and you can see that participation in the treatment oral immunotherapy was associated with relative risk of anaphylaxis of 3, epinephrine use of 2.2, serious adverse events, reactions, and causing study discontinuation of relative risk of 1.9, and allergic reaction by organ system involvement. You could see that it also was increased in the patients undergoing immunotherapy. So this is a treatment that has side effects. It is important to be honest about it with the patients. And I'd still say that many parents, many caregivers are still very favorably are looking at this treatment very favorably because they feel that those adverse symptoms occur under their care and when they can treat them. I think the big questions for us, even though we do accept that the more modest goal of desensitization, but ultimately everybody would like to know, can we stop the treatment? Are we still going to be protected? So is it possible to achieve permanent oral tolerance? So I would refer you to the POISE study, which was published in Lancet in 2019 from Stanford. It was a single-center, randomized, double-blind, placebo-controlled phase 2 clinical trial that enrolled 120 participants with a median age of 11 years, who were on peanut OIT maintenance of 400 milligrams, so almost like a full dose of peanut, or placebo for 104 weeks. After 104 weeks, peanut OIT patients who received active immunotherapy were randomized to either continue at 300 milligrams of peanut protein daily or to stop treatment, so resume strict avoidance. And then those patients underwent repeated double-blind placebo-controlled food challenges at week 117, 130, 143, 156. So it was remarkable in itself that patients were willing to come for those repeated challenges. And you can see that compared to week 104, when you see there's no difference, but sort of a good response rate in terms of the passing of the food challenge. You can see that already after 13 weeks, there is a drop in the number of patients who are able to tolerate the full dose among those who discontinued immunotherapy, which was further obvious at week 130, 143, and 156. Those who continued at 300 milligrams, so sort of the currently available drug, there was a decrease between week 104 and week 130, but then sort of stayed at the same level. And you can see that close to 40% of the patients were able to tolerate full dose of peanut. So 3 months after discontinuation of oral immunotherapy to peanut and strict avoidance, 35% of participants retained the ability to ingest full dose of peanut protein without allergic symptoms. So depends how you look at this, whether it's successful or if it's disappointing, but it suggests that even with the high dose immunotherapy, after 2 years, discontinuation will lead to loss of protection in the majority of the treated subjects. Just want to share with you the results from our wheat OIT study with vital wheat gluten, and the results actually were less promising than with the peanut. The patients who were enrolled were highly allergic patients with wheat allergy, and you can see that desensitization was achieved in 52% after a year with the max daily dose of 1445 milligram wheat protein. And then those patients who were on placebo crossed over to the high dose of an OIT with wheat protein, 2748 milligrams, and patients who were originally actively treated continued. And you could see that 57% achieved desensitization after a year, but only 13% of those treated for 2 years retain ability to ingest the full dose of wheat serving after discontinuation of wheat OIT for 8 to 10 weeks. So indeed, this is a very long-term commitment. The patients increase their threshold over time, but discontinuation of the treatment sort of reverts them back to where they were. Since side effects, allergic reactions are so common with OIT, there was a question whether anti-IgE could improve safety and efficacy. So again, this is a California study from Stanford, phase 2 clinical trials, NIH sponsored single center, ages 4 to 15 years who reacted to less than 500 milligram food protein at baseline, double-blind placebo-controlled food challenge. And they were randomized 3-1 to omalizumab or placebo plus multi-food OIT, and the number of treated was 48. So the patients were underwent a double-blind placebo-controlled food challenge at the week 0, then started on omalizumab placebo, and then after 8 weeks, they were started on multi-food OIT. Omalizumab was discontinued by week 16 versus multi-food OIT was continued until week 36, where patients underwent a repeat double-blind placebo-controlled food challenge at 2,000 milligram of food protein. And the results are quite interesting. Desensitization, which is defined as those passing 2 gram of challenge to more than 2 foods, was much higher in the omalizumab and OIT group compared with the placebo and OIT group, which is statistically significantly different. There are significantly fewer adverse events per subject in the omalizumab and OIT group versus placebo and OIT. But there's no serious grade 3 adverse events, and there's no withdrawal from the study. But it suggests that even though omalizumab is currently not approved for food allergy, it has the potential to improve the safety as well as desensitization in the patients treated with OIT. So I mentioned before there are different types of allergen-specific immunotherapy. So they're both they differ significantly in terms of the dose, maintenance dose. Maintenance dose for OIT is between 300 to 4,000 grams, 300 milligrams to 4,000 milligrams. For epicutaneous immunotherapy is much lower, about 200 micrograms. For sublingual immunotherapy, about 2 milligrams of food protein. For the updosing, there is a pretty significant schedule for the OIT. There's no updosing, so to speak, of in EPID, and there's very limited sublingual immunotherapy updosing. All of those treatments are daily treatments, and the efficacy is higher for OIT, lower for EPID and SLIT, but the safety is also much of a concern for OIT with systemic reactions, gastrointestinal symptoms, as well as eosinophilic esophagitis. For epicutaneous, the symptoms are mostly limited to local skin reactions or sublingual immunotherapy to local oropharyngeal. So I think that there's like a conceptual framework. So if you have a patient with mild food allergy, with a high threshold, no history of anaphylaxis, low specific IgE, who is younger, then this patient is probably a good candidate for oral immunotherapy and would require lower dose, cumulatively lower dose and shorter duration, and might achieve sustained unresponsiveness of intolerance. Those with moderate food allergy, so moderate to high threshold, plus with or without history of anaphylaxis, moderately elevated specific IgE, but still younger, those patients will need a longer duration immunotherapy with a higher cumulative dose. But they also have a potential for achievement of to achieve sustained unresponsiveness. But those with very severe food allergies, such as low threshold of reactivity, history of anaphylaxis, high specific IgE, older age, these are patients that will be very difficult to desensitize effectively. They will may struggle with the immunotherapy, and maybe we were not talking about cure. We're talking more about the remission in their cases. So, in summary, food allergies are common in the US among children and adults, but they're also common in other parts of the world. We have the peanut OIT, which is the first FDA-approved biologic drug for food allergy, which does validate the concept of oral immunotherapy, but there's no other products that are approved. The indication for OIT is desensitization, with hope that that tolerance might be achieved by some patients after many years of therapy. Um, at this point, avoidance and emergency management remain the mainstay of therapy. So thank you very much for your attention.